Mr. Watts is the CEO of the National Healthcare for the Homeless Council and a member of the Biden Health Equity Task Force. The Council supports 300 federally funded healthcare for the homeless programs and 100 medical respite providers with training, technical assistance, sharing of best practices, research, active policy, and advocacy work to eliminate homelessness. Mr. Watts has 25 years of experience in the direct service and implementation of homeless and health shelter services. Mr. Watts?
Thank you very much. I'm very honored to be here and thank the National Institute for Healthcare Management Foundation for convening this important gathering. And I'd like to first apologize to all those in attendance. I need to leave a little before the top of the hour. And I was sent some of the questions that were submitted in advance, and we'll try to address those in my time. And I'm glad I can at least stay to hear all of the other presentations. So would like to begin by introducing very briefly what the Council is, and the best way to do that is through our mission statement. We finished a strategic planning process about a year and a half, almost 2 years ago, and one of the things that followed was a new mission statement. And it is grounded in human rights and social justice. The National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. And I want to point that out before a few reasons. Our mission statement says who we are, what we do, why we exist. And we start off by talking about grounded in human rights and social justice. We view healthcare and housing as human rights and working to advance and to secure those rights as a matter of social justice. We also were careful in our words. We want to build an equitable, high-quality healthcare system. We believe that you can't really have high quality unless you have equity. High quality for some is not the high quality that we want, so it must be equitable. And then our main ways of supporting the 300 healthcare for the homeless federally qualified health centers and 100 medical respite program is through training, research, and advocacy. And our ultimate goal is to work to end homelessness. We know we can't do that by ourselves. We're part of a larger movement to do that. So I want to talk a little bit about, just very briefly, about the relationship between homelessness and health, because you will see tremendous disparities between the health status of people who are housed and those who are unhoused. And one of the key things is just to understand that the connection between homelessness and health is a strong one. Homelessness can lead to poorer health. In many cases, poorer health leads to homelessness. And we see this slide, the data on the left really is for single adults. When we look at homelessness, we will see there are a large number of single adults, but a very significant number are those in families, and they have somewhat different health profiles and dynamics affecting them experiencing homelessness. We'll see that higher rates of behavioral health, some of these life-controlling conditions that we now understand are more and more are medical conditions and not matters of personal wills, mental illness, substance use disorders, and drug overdose is, for many years, has been one of the greatest cause of death among single adults that experience homelessness. When we look at the health status of people experiencing homelessness, we know that the best health status is among those who have been housed. Next is if you're in a shelter, your health is better, but not as good as if you were housed. And as not surprising that among those who are unsheltered, they are in the poorest health. They are 2 to 4 times more likely to die in a given age group than sheltered homelessness than those who are sheltered, and 15 times more likely to die than the general population. These are age-adjusted mortality data. One of the most shocking things is that among those who are unsheltered, the average age of death of those who die while living on the streets, under bridges, in parks, in the richest nation on earth is about 20 to 30 years younger than the general population. Generally, it's been around the late 40s to early 50s, while the average age of the general population, the average age of death among the general population is around 78 to 80. So we're losing 20 to 30 years of life. During COVID, there is a lot of missing data, and I will address missing data a little bit later. But from the data that we do have, we don't collect homelessness data well, we don't collect mortality among people experiencing homelessness, and then there was the gap of COVID data among those populations. But where we did have data, a national survey, and there were of different cities where the data collected was differently, but it found an average increased mortality rate of 30 to 40%. One of the places that has the best data is New York City, both housing data, and homeless data, and cause of death data among people experiencing homelessness. And through August of last year, so really one of the early big parts of the pandemic, they found a 78% increased death rate, that's age-adjusted death rate, from COVID among people experiencing homelessness. So want to just look at the composition of who is experiencing homelessness in the United States. There were almost 600,000 people that were estimated by the U.S. Department of Health and Urban Development, HUD, that were experiencing homelessness on a single night in 2020. And this was in January, late January, early February, so before the pandemic. And we see a few things when we're looking at the homeless status. We see that about 37% are those who are in families, so more than a third of people experiencing homelessness are family members, are two parents with children, or a mom with children, or a single dad with children. But these are, and most of those who are in families are children. So a tremendous amount of number of people who are experiencing homelessness are children. We also see that racial minorities are overrepresented among people experiencing homelessness. African Americans are between 12.5% and 13% of the general population, but 40% of those experiencing homelessness. Likewise, Native American are also greatly overrepresented among people experiencing homelessness. And we also see among those who are experiencing homelessness, we see more males than females. Want to talk next about equity. And when we talk about equity, I want to make clear that not all disparity is necessarily due to inequity. So I think it's important to look at our definition of equity, and many people have different definitions, which is why I didn't write mine down. But in talking with a number of people, I've kind of come up with my own. One of at our national conference last year, I had a chance to have a conversation viewed by our participants with Dr. Ibram Kendi, the author of How to Be an Anti-Racist and Stamped from the Beginning, which won the National Book Award, and asked him what was his definition of equity. And it's very similar to one I use, so I'm just going to adopt it. And it is basically having what is needed for a fair opportunity at success. Having what is needed for a fair opportunity at success. Another way to put it is that people are given a fair opportunity, are given what is needed so that they have a fair opportunity at success. So when we think of health equity, then we have to look at, that means that people have what is needed for a fair opportunity for health. And when we can see that as a nation, the amount of people that are experiencing homelessness in the richest country on earth, and the effects of that on their health, we can see that homelessness leads to health inequity. We are the only wealthy country in the world that has this kind of disparity, this number of people that were born and raised in this country that are experiencing homelessness. As was mentioned, it's not by accident that we find people of color, racial minorities, especially African Americans and Native Americans, greatly overrepresented among people experiencing homelessness. This is the result of structural inequity, structural racism from the beginning of our nation, and whose practices, not just the legacy, but the practices continue today, with redlining, how we choose to fund our schooling system, our education system, our policing practices. All of this leads to people greater overrepresentation of people of color among those experiencing homelessness. One of the statistics I like to cite is that we see that marijuana usage among whites and blacks is almost exactly the same, yet a African American is 4 times more likely to get arrested for marijuana possession than a white person, and that is purely a function of policing practices. Where are the policing stopping people? In which neighborhoods? Which cars are they stopping? Which ones are they searching? We see that when police stop cars and search them, they find drugs at the same rates among blacks and whites. So it is really a representation of inequitable practices that leads to homelessness, that leads to inequitable health outcomes, and therefore health inequity. So there are some ways we can get closer. What are some of the solutions? There are 2 buckets of solutions. One is universal. Again, other countries don't have this type of health disparity among people experiencing homelessness. They have universal health care. We don't have that in this country. We also don't have this type of homelessness. They are closer to recognizing housing as a human right and seeing it as the responsibility of the society to provide minimal adequate housing for those in need. We saw some of that with the pandemic, where the CDC said in order to protect people during this pandemic, there was a moratorium on evictions. So some universal ways can really just raise the floor for everyone and wipe out some health inequities. We see that we have like a natural experiment going on with the Affordable Care Act, and which states expanded Medicaid and which states didn't. And among healthcare for the homeless programs, we've seen huge increase in access in Medicaid states versus those that don't. Now, in the healthcare for the homeless program, as federally qualified health centers, they will serve everyone regardless of their Medicaid status, their ability to pay. But the discrepancy comes when you need to refer someone to a substance abuse program, a mental health program, for a specialist to get their heart checked, or any medical condition. When in the non-expansion states, there's much less access and people are in poorer health. Another way is through tailored solutions. So you can have special services. The whole healthcare for the homeless movement realized that just creating the healthcare system did not mean that it was accessible to people experiencing homelessness. There were lots of barriers, including mistrust by people experiencing homelessness because they had been mistreated by the healthcare system. So needed to have special outreach, special services, needed to make sure we were addressing the full person from the very beginning. This has been our model for 35 years, integrated health with behavioral health, primary care, social services, addressing the social determinants of health. Because you can treat someone's blood sugar, but if they're still sleeping out under a bridge, if they don't have a place to store their insulin, then you aren't really addressing them. We knew we had to treat the whole person. Special services. Also, all healthcare for the homeless programs have some kind of special outreach. One of the questions that came to me was what can be done about homeless youth? And I saw that previously NIHCM did something with homeless youth. And wanted to drive this principle further, take it further. One way to address health inequity for youth experiencing homelessness is to have special services targeted to them. So there are a number of special shelters for homeless youth which is really important because they would not feel safe or welcome in a general shelter, and they need special services. They need to make sure that they're being able to connect to school. LGBTQ youth are at much higher risk of homelessness, so you have to make sure that your services are friendly for them. And then we also have to take into account where are they in their developmental continuum with their developmental growth, and make sure the services are targeted for that. So 2 key ways to address health inequity are universal, lifting the floor for everyone, that everyone has more of a minimal opportunity to get what they need for success or for health, and then to make sure there are special targeted services. Hit the wrong slide. I am done and just really want to thank all of you. And I'm sorry I won't be able to stay for questions, but if someone email to me, I will do my best to answer them. I turn it back to our host. Thank you.
Thank you so much, Mr. Watts, for giving us a full look at the scope of homelessness and the impact of homelessness on so many people in America and the barriers to change. We really appreciate it.